Well, hello, everybody, and welcome to It's Worth a Shot, our weekly series here at Mountain Pacific. We're happy today to have a guest speaker with us who's going to talk about a program in Montana, Simulation in Motion. Her name is Suzanne Hill. And so we're excited to have her share with us what's going on with that program in Montana. So we can go to the next slide. Just a couple updates and reminders. There is a new training module that is specific for COVID-19 for NHSN that's posted on the CDC website. We'll have the link there. Maybe we can throw that link in chat as well, Miranda or Lori, if you wouldn't mind. So check that out. That just came out in June. And then just a heads up that we're starting to do our influenza vaccine clinic planning. And that might also involve some other vaccines, including COVID-19, the updated version. We're waiting on that. We expect several of the drug manufacturers to come out with the newest recommended formula this fall. And then also we might be doing some RSV vaccines. So we will keep you guys updated on how that progresses, and you can reach out with us to questions about vaccine planning or support that you might need from us as well. We can go to the next slide. So as always, if you have topics that you'd like to see here, ideas, things we haven't covered, things you need more information on, always let us know, throw it in the chat, send us an email, and we'd be happy to present on timely topics that are useful to you. And I think we have a polling question here. All right, our polling question. How many people have NHSN access in your center? Okay, so we're seeing kind of a tie between 2 and greater than 2. But 2 looks like it might be the winner here for the number of folks that have access. We really appreciate you answering these questions. They help us gear future education and really be able to give the support that we need to all of you folks. We can go ahead and end that poll, Mary. Thank you. And we can go to the next slide. So just taking a look at our weekly COVID rates, hospitalizations, and deaths, both on the decline. This is good to see. And we are in the summer months, so that's kind of a normal trend. You can go to the next slide. There are a couple pockets across the United States where we were seeing a change in hospital admissions for COVID-19. And you'll see in the orange, there is one small pocket there in Montana, which is probably a small number of folks, but definitely we're just kind of seeing it here and there. And so still something to keep track of in your communities. And we can go to the next slide. All right, Suzanne, I'm going to turn it over to you. I'm excited to learn about simulation in motion.
Thank you so much for having me. I'm just saying hello over here. If any of you see me over on your photos, I'm waving, and I'm going to go ahead and bounce back out of my video. And before I get started, I'm just going to give you a quick summary of what I'm going to present today. We'll get a little history and background on what we do, and then a sample program that we've built. And at the end, I think it'll become kind of obvious why I'm giving you a little more context about it that will seem to have not much to do with you, although the COVID update right here actually is a surprise to me, so it might be a neat segue. But my goal is to just really give you guys a great insight on some stuff that we do, how we build our programming, and then at the end we have some neat stuff going on with long-term care specific programming that I'm eager to share with you. So next slide, please. All right, so like any good product or service, we came to be out of overcoming a barrier or a challenge set. They're wide and varied, but a few that I wanted to share with you: inequality in training access between rural and urban Montana areas. So they have smaller budgets. It's harder for folks to travel for training, and there's a burden on the remaining staff with fewer to fill in. So training isn't necessarily not important to these facilities, but it is a harder thing for them to achieve in a consistent way than in urban areas. And then communication breakdown is a thing. And this presentation I'm going to share with you, it's a summary of a program we just wrapped up, and it actually exposed to us even more importance being placed on communication and the breakdown and what it causes. Just a few things: obviously increased errors, duplicated efforts, and inefficient systems. When communication isn't happening well, that's obviously going to be a consequence. And then relationship breakdown is inevitably something that occurs when it's ongoing. Next slide, please. And burnout, before COVID, it was a thing. Certainly now it is a bigger thing, but lower volume and reps than in urban areas. This is more specific to the healthcare and EMS clients that we serve. Folks don't see the reps and the volume that they might see in a larger area, so they don't have the confidence or the job satisfaction that they might have in a different area. We like to address that as often as we can. We call these specific events we target in the medical fields high impact, low frequency events. They're things that folks don't see all the time, but because they are in a rural area, but when they do, it's a very, very big deal. And they often know the person and the patient. So that can even be a more consequential experience for them. Some of this can lead to low job satisfaction and a resulting high staff turnover. There is an aging workforce, especially in rural and volunteer fire and EMS. However, something that we're really focusing on right now is kind of the confluence between that aging workforce retiring with the experience and the younger workforce that is coming in, but lacking the experience. So obviously training is a solution there as well. COVID, Lord knows you guys know what that means. And we're seeing a lot come out of that. And I'll discuss some of that in this session here. And then something that is really important to us, and working with your organization has actually helped cement some of these ideas that we've had, and we're really enjoying working with associations like yours to determine exactly what this means. But long-term care is an overlooked segment of healthcare, always has been. But something that we've had reports of, is during COVID specifically, there's a lot of celebration about a lot of the heroes taking care of folks during COVID, and oftentimes those banners are being flown at a hospital right next door, and the long-term care facility may or may not have even been noticed. So that means something to us, and we want them to feel seen. So we're working really, really hard to develop programming to serve this segment well, starting this year. Next slide, please. So Simulation in Motion Montana, we were started in 2015 through a partnership with Helmsley Charitable Trust and Department of Public Health and Human Services here in Montana. Helmsley has started organizations like ours in a small handful of other rural states. And, as you folks are out there listening, if you're in Montana, I am your contact, and my contact information will be at the end of this. But if I'm not in your state and you'd like more information, please also take my information down, and I'd be happy to help you identify if there is something like what we do in your state, and see if we can't get you guys training you may like to see happen in your organization or in your community. So obviously things we were here are brought in to address would be the problems I just mentioned, and to bring equity in rural areas, not just in care, but also in training, so that folks living there feel safe and the job satisfaction of the people serving those folks is high. To spread the word about new protocols and best practices, we often work with the state to roll out new treatment protocols. New information is best, simulation is extraordinary in its efficacy. So like right now we're doing a TBI rollout for brain injury, a new protocol for that for the state of Montana. And it's really fun. We love doing it. And so obviously providing really high quality simulation training, and to partner with state agencies and groups to tackle funding challenges. And this is something I want all of you to really pay attention to, because we've got some really neat programming coming, and your budget does not need to be a barrier. So if it interests you, please do contact me and I can help you. If it's the training I'm talking about today, the funding is aligning right now. And if it's not that training, you want something else, we'll help you find training or funding for that too. So next slide, please. So in 2015, the organization was formed. It took a few years for everything to come together and all the T's to get crossed and I's dotted to get this stuff on the road, literally. So we've started serving people and training folks in 2018. Since then, I actually ran the numbers this morning. We're north of 12,000 learners today across more than 20, and I would say medical-ish professions. We do, a lot of the allied health and some of the more advanced health professions that are not, totally clinical. We do a lot of that training as well. This number is a little variable. We serve a lot of people. It's up for debate how many folks actually travel through Montana, whether they're a visitor or resident, but it's a lot. We are sure it's north of 2.3 million, likely higher. We trained over 152 different Montana communities across 52 of the 56 counties. And most of them were in rural Montana. We also served Idaho and Wyoming in a considerable way as well. Next, please. So simulation training is extremely effective. It reduces medical errors, it improves your patient outcomes, it increases team performance, and it identifies patient care threats that otherwise may be unnoticed or unassessed. Next slide, please. High fidelity simulation is a bit different. And the difference is because our mannequins are incredibly lifelike. They breathe, they bleed, they talk, they give birth, they cry. And they do all of this when they concurrently changing their responses based on the care that they receive. So the stakes are not as high, but we can create a pretty stressful environment in a positive way, a stressful environment for the folks who are working on their skills so that we're really pushing them to grow, but the stakes aren't as high as if they were learning on a human. So it's very effective and creates a tremendous growth in their job satisfaction. Fun fact, Hal here, he's our 7-year-old pediatric mannequin. He's the most lifelike that we have now, and his eyes will track you as you move around him. His pupils will dilate. He'll talk to you. He is a trippy little fella, and he really sells the training really well. Next, please. So these are a few reviews. I'm actually working on another project today, and I literally cannot get my head around how many amazing reviews this organization gets. But here are a few of them, and just some high points in them. As close to a real life experience as you can get. The scenario unfolded, so participants were left to work through each scenario in a real life way. And I learned a lot about myself and my own clinical skills. I feel more confident as a nurse. But like I said, they just go on and on and on. I honestly don't know that we've ever gotten a negative review. So I'm really proud of our team and the trainers that we have. They do a dynamite job. Next. So in a summary, so Montana, we're mobile. These are the three trucks. We have 3 trucks that serve all of Montana. The goal being oftentimes folks don't have room to spare within their facility to do the training that they need. We'll just roll right up into their parking lot, and their staff can run through our simulations in a way that
got home safe and sound.
And anyway, so these trucks are able to overcome the barriers that we discussed earlier on here. You know, folks don't have the time, the money, or the space. We can overcome all of those barriers by bringing our truck right directly to them. We're also, we have a fleet of vans, a handful of vans that can get there. So we're no longer having to cancel events due to the weather or road conditions. And we can bring our mannequins in situ, meaning we'll take them into your facility and use your equipment and your space and your systems if that's the best use of your training time. We love to do that as well. Customizable if you have a training that you're interested in. It does not have to be the one I'm about to talk about. Certainly, we train all day long on all different things. And our favorite thing to do is really talk about the objectives and the outcomes that the facility needs and back into those with a unique training built just for them. And we're a nonprofit. So funding, in our opinion, should never be a barrier to quality training. Our goal, and Helmsley put a lot of money into this up front to make sure that this overcomes the barriers that I spoke about, and cost is one of them. So again, if this interests you, please call me. I'd love to chat with you about your possibilities and see what we can do for you. And again, we're innovative. We're always trying to listen to the market and to the changing, whether they're actually changing facts or facts as they are exposed to us. We want to make sure that we're responding to those and being as available and positive serving as we can for the state of Montana and our flanking states. Next. So about a year ago, and I'll back up just a sec, we historically always just ran our sims like we would do a block of 2 hours. We'd run a learner through, or 4 to 6 learners through a sim, and they're going to get some extremely good skills training and a lot of team dynamics improvement. And then we wrap it up, and there's a debrief afterwards. That's extremely effective. But those blocks were 2 hours at a time, so we could run about 24 learners through, and our feedback and our results are incredible. But about a year ago, Montana Hospital Association asked us, they had some leftover COVID money, and they asked if they could please try something new. So we had of course, our team loves doing stuff like that. So we did the mornings instead of the whole day. We actually broke just the mornings into sims. So we ran all their learners through the skills for an infectious disease patient. And then in the afternoon, we did a tabletop where we would discuss all of the gaps that were identified during the skills portion. And more importantly, how could we bridge those gaps and where could we cover up some inefficiencies and inefficacies that were existing in those systems? So in this particular training, these 5 objectives were important to them, reviewing the existing assets for a rural outbreak and a patient search for an infectious disease, reviewing roles in all the partners that came together to serve this patient, identifying gaps in communication, and identifying changes in protocol for both EMS and the respiratory protection program, and also in public health department, EMS, DES, any of the other protocols that came together, just kind of based on their roles and involvement. And that varies by community, as we all know. So this was the summary of what we were trying to uncover and identify gaps in. Next, please. So again, in the morning, we ran through skills. So the scenario was a disease outbreak with a patient surge in rural Montana, and it was important that all the key partners were aware and responding as they would in a real life situation. EMS was dispatched. The patient was then handed off to the ER. The child was sick for a bit, for almost a week, and was now unconscious. Dad notified the EMS that the baby had been, or that the family had been in Yellowstone, but the mother had just returned from Africa, which was really important for them to hopefully systems should have reacted to that information. And the child is bleeding from the eyes and nose and had blood in the toilet paper and diaper this morning. So these should all have spawned parts of their systems, obviously. Next, please. So during those skills sessions, gaps were identified. We followed those folks through that entire simulation, had a debrief afterwards, ran another group through, had another debrief afterwards, and then came together as a group in the afternoon to have a really honest discussion of what we saw. We reviewed protocols and processes, we reviewed skills and actions taken and the observations that were made by us and by the partners. And our team is very, very, very good at the debrief process, which is where you find the dissonance and you get in there and you uncover what's causing it, and then you build them back up and you send them back into the field stronger. And there was a lot of that occurred. We would generate a plan for moving forward, which we'll talk about in a second. And we identified and discussed strengths and opportunities for improvement for each of the objectives that you saw. Those were all determined by the funding source. Next, please. And so we identified, or we created an after action report. And so during that morning session, we were paying very close attention to what was going on, identifying gaps. That was the point. It was not disappointing when we identified them. That was the purpose of the whole training. And then we built a report, like I just mentioned here, and with the point of actually solving the problems and building up those relationships and making sure that when we come back next year and do a similar training, that they've buttoned some things up. A few of the things that we uncovered, there was a laundry list of things, but these were the common ones that were almost present in every place. The pediatric crash cart was never, I don't think it was ever once in the ER. So you would get that patient. And by the way, I should clarify, this was a highly infectious disease patient. It was a Marburg patient, which you don't want to contaminate your hospital with that. So the Peds crash cart was never in the ER. They would get in the ER, the door closes behind them. And in theory, in a perfect situation, it's likely that the people in that room are probably not coming out until lots occurred. But the door would fling right back open and they're fetching the pediatric crash cart from somewhere on the other side of the ER. So contaminating the ER. PPE complacency was another thing. A lot of the folks are used to just kind of looking at our trainers saying, hey, I'm simming out, that pretend I'm putting my mask on because they don't want to use the equipment and waste it. But our team learned that if we said, no, let's go ahead and put it on. The next thing that was discovered was they were either out of stock, they didn't know where it was. And if they did know where it was, many, many, many times they didn't know how to doff the PPE properly, which, as we all know, is also a pretty consistent point of infection or contamination. EMS communication and the sheriff's dispatch communication, there was some lacking communication there, and we definitely found some places they could have improved all of that. There were no long-term plans in place at most of these facilities for caring for a patient with such an infectious, severe disease and issue. And then uncertainty was kind of the magic one here. And also lack of awareness of how serious a situation like this would be, and then not seeing the incident command system being employed. Those were all things that were a pretty big deal. But I'll go back to uncertainty, because out of this program, almost nobody knew what their local specimen transport protocol was. And equally, a lot of folks sort of speculated what they would do as far as transporting that patient, but nobody knew for sure. A lot of folks would say, we're going to fly them, or we're going to send that specimen on a courier, or our highway patrol will take it. But the truth is, actually, none of those things would have occurred, and they didn't know that. So public health saw this, and the state lab saw this, and they, within just a few weeks, once they saw all of our data that came out of these programs, they had built a state protocol for patient transport and for specimen transport. So that was a huge win for us, because actually we were able to go now as a wrap up, and it's a really rare opportunity that we get to build a program, execute the program, assess the program, and then go report back on all the data of actually seeing some success in that program. That happens in other worlds, but it doesn't always happen in ours in the training world. So it was really neat to be a part of that. And it's made a big difference in hospitals feeling like they're covered in a plan. Next slide, please. So as a result, Sim Montana has changed a lot about what we do. Like I said earlier, we used to train folks on skills, and we still do it, and we do it a lot, and we're really good at it. Anytime we can, when we're building programming, and we're building programming that requires funding from a grant or a donor, it's really important to us that we deliver on that. And we feel really strongly that having that tabletop component and just that united communication tree discussion is really important whenever it's possible. So right now we're working really hard to develop and execute an opioid and overdose support SIM program. It'll be working in many cities in our communities in Montana, where there is already a plan and a tool and a protocol in place to address and hopefully, reduce fatal and non-fatal overdose in Montana. And we'll be building that out, simming out the skills and supporting the overdose patient in the morning, and then really working on that communication piece in the afternoon to make sure that those folks know how to execute well the communication portion of that. We're building out an online solution for EMS recertifications. It's pretty cumbersome, and it's taken a really neat turn with the state's involvement. So hopefully that'll come through as well. We're working really hard on a pipeline and workforce support program, meaning, building a lot of passion for healthcare and EMS in youth and folks who are kind of looking for a career path, and, finding some neat ways to accelerate that. And we're having some luck with that. I'm going to wait on this funnel up on the top here, because that's pretty important to this group. Just interagency and regional communication support, mass casualty, and honestly, just system testing for any group that needs communication. I actually had a meeting today with a large bank, and they kind of wanted to see if our SIM guys could come in. And obviously the healthcare component's not there, but the communication is, and certainly the navigating tough conversations is, and we're working that out right now. We have a lot of corporate opportunities, and we work with universities a lot. So that's an ongoing deal. And then we're actually building a really neat program right now for mental health support as well. Again, there's a protocol in place for suicide prevention. A lot of folks don't either have that protocol, or they may have a variation of it. So we're trying to get folks on the same page so that communication works like it should. And that program has some good legs too. I actually just got an email today that sounds like that one's going to get off the ground pretty soon too. And then most important for this group, geriatric dementia and long-term care support. This is so exciting for us because, this is a market that, full disclosure, I think even we really hadn't been paying close enough attention to. So one of our trainers is probably the most passionate person I know when it comes to serving this population. And we are making some stuff happen, and it is really fun to watch. So we're working with several Alzheimer's groups and a couple of grant sources and some funding sources to develop some programming that does exactly what I just mentioned. We're very interested in making sure that the folks and the providers in these care centers have the support that they need, that they feel seen, and that they feel supported. They take care of people that are very important to us, and they do the things that a lot of us forget is even occurring. It's really, a powerful field. So this particular programming right now, it doesn't have any testing, and that's why I wanted to really run through something that did. It's something that we built from start to finish, and it was incredibly successful, and I very much expect the same from this program as well. But if you take what I just mentioned and just kind of expand in your imagination, we would have skills in the morning, we break for lunch as a team, and then come back together. And so all the partners that might be involved in, from assessment on through acute care and long-term care for any patient that's going through, whether it just be an acute situation within a normal long-term care environment, or if it is actual onset of dementia, and we need to deal with making sure that all the partners are coming together to do the best thing for that that patient, for themselves as a crew, and also for the stakeholders in that patient's life. And then identifying gaps and building the stronger plan and moving forward with some neat follow-up in place. Something that was really interesting to me, and I don't know if any of you on this call have talked to me before, but I was just floored when we were meeting with some Alzheimer's ladies, and they mentioned that one of the, main first stops for identifying or noticing early onset of dementia is the library. And I never knew that. And of course, I mean, I'm from small town Montana, and of course it is. And if it's not the library, it's a similar group or environment in that community that is noticing these folks and knows these folks. So bringing them to the table and bringing folks like them to the table to make sure these communities are doing the best they can to support these patients. So these programs are coming to communities in Montana. And I would just say, as it pertains to this geriatric and long-term care support and dementia and long-term care support program I just described, one of the grant sources that we are working with right now is requiring letters of support from Montana facilities that, they say that they would like to take part in something like this, knowing that it is fully customizable for their facility, and that we would work with them to make sure that it met their specific needs and delivered. So if any of you are interested in being a part of that, I would really love to talk to you. And I actually need to talk to you for us to be able to get this off the ground. So please don't be bashful and reach out to me if you wouldn't mind. And if you have any questions on that, I'm certainly here today to talk about that, but I can talk about that anytime. It's what I do. Next slide. That's me. So there's my contact information. And again, I'm yours anytime you want to talk. And I'd be happy to answer questions now if you have any.
I am just so impressed. What a cool program. And I bet this group is going to be excited to see that geriatric component. So we will keep information as that evolves, the development of that. Mountain Pacific can serve as a intermediary to connect you or keep you up to date with information. Suzanne, thank you so much.
Absolutely. Thank you. I really appreciate the opportunity to share this with your group.
So I do see a question. Are any of you from long-term care still doing COVID-19 vitals? Ooh, it moved on me. And nurse assessments, or did you stop them at the end of the PHE?
Is that question's not directed to me, is it?
No, I'm
Okay.
sorry.
They're asking the
Yeah.
participants on the call if any of the participants are still doing the COVID vitals and nurse assessments.
Gotcha. Okay.
Looks like in chat we have somebody stopped. Another discontinued, stopped. Yeah, so it looks like the majority of people have stopped. You can go to next slide, Mary, and then the next slide.
So I was just thinking, and I'm thinking out loud here, if you wanted, you do have a draft, like kind of letter of support, or would that be something that we could work together on to distribute to folks so that makes it a little bit easier for them to do that?
I do. I have a draft, and I would love
Okay.
to work with you to make sure that this draft really applies to them and they feel confident, submitting something like it.
Okay. Yeah.
Would
We
you
can
be
send
my
it out
contact?
probably
Yeah,
via
once I
our
get-
listserv, I would think.
Yep.
Okay.
And I
Would
can
you-
also send it out with next week's reminder for it's worth a shot if it's finished by then.
Yeah, I could probably turn it around within a half an hour. I've got it.
Awesome.
Great.
Yeah.
We want to thank everybody for joining us on the call today. And just wanted to remind you that we do have the evaluation in the chat. So if you'll complete that for us, it just definitely helps keep us on track and, make sure that we are meeting your guys' needs and that we are bringing you new and useful information and not just wasting a half hour of your guys' life every Wednesday. So next week, we actually will have Carmen Bowman from Wyoming, and she will actually be having the whole webinar about the Wyoming culture change projects that she works on. So we hope that you can join us next week, next Wednesday. And yeah, have a great week.
Thanks, everybody.
Thank you. Bye-bye.